Welcome to the Dr. Berkson's Best Health Radio Show. Today we have an incredible physician on the show talking about an amazing topic that I've been getting emails, letters, texts from people saying, please do a show on this super immune booster called LDN, which is an acronym for Low-Dose Naltrexone. So I'm going to tell you a tiny bit because we have one of the world's experts on LDN on the show today. And then I want to tell you how it happens that Dr. Pamela Smith has graced us from Michigan with having this very informative and important dialogue today. So low-dose naltrexone, we're going to let her go into it, but if you just put it into PubMed, I thought, well, before the show, I'll just go to PubMed, which of course is the National Institute of Health's abstract service, to get you in touch with all the incredible elbow grease of scientists and physicians around the world. So you can put in a name and then click search, and you see mostly, not all, peer review articles that give you an idea of what's going on with this topic. So I put low-dose naltrexone in, and immediately the first three topics that came up was low-dose naltrexone, a review of therapeutic utilization, which discussed its use in multiple sclerosis, Crohn's disease, fibromyalgia, pain relief as an anti-inflammatory agent, and on and on. And the next article that came up was low-dose naltrexone, a promising treatment in immune-related diseases, mostly autoimmune diseases, and cancer therapy. The next title that came up was the use of low-dose naltrexone as a novel anti-inflammatory treatment for chronic pain, just at a time where we're seeing the damage of the opioid crisis. So I asked Dr. Pamela Smith, I've actually been nudging her for a while. Dr. Smith is famous in functional medicine. We're going to be talking about her books today because she writes phenomenal books. She calls herself an anti-aging medicine specialist, but honestly, she's a specialist in so many things that if I started to list them, we'd use up most of the show for that. She is sitting right now in front of a gorgeous bay in Grosse Pointe Farms, Michigan. And in her career, she spent the first 2 decades as an emergency room physician. And we know those ER docs, as we're seeing now with the COVID crisis, they are our heroes and heroines, and they're very smart people. You want a workup, a real workup, you go to an ER doc. So she worked at the Detroit Medical Center, but she's since become absolutely internationally known as a speaker and author on functional medicine. In fact, I talk a lot about how I lecture at the A4M gastroenterology module. Well, I believe that Dr. Pam, she's the one that came up with the idea of these modules. I mean, if we look at a lot of the ways a lot of our functional doctors are being trained, Dr. Pam Smith is behind a lot of that. Now, her whole name is Pamela W. Smith, and I'm going to ask her what the W stands for when she's on. But I want to, and by the way, she and I, for the whatever the fickle finger of fate has unveiled itself, we've ended up speaking quite a bit together. Probably over the last decade, we've spoken at maybe, 30, 40 conferences together. And a few months ago, she and I were the whole show, a 2-day weekend on hormones for pharmacists, medical doctors, nurse practitioners. It was just Pam and I doing the whole deal. And in the evening, I did one of my first stand-up comedy routines, and she did one of her sit-down nutritional public talks. So we've been frickin' frack, and over the years have really realized how much each of us work very hard. And that she said in her email this morning, I loved it, that we were both born to do this. So welcome to the show, someone who I think is an amazing human being. Welcome, Dr. Pam Smith.
Thank you so much. It is truly a pleasure to be here today.
So what does that W stand for?
It stands for my maiden name, which is Wardian, and it makes it really nice because I spent my whole life growing up having to spell my last name. When I married, my last name is Smith, so I don't have to really spell that. So it kind of makes it nice. It makes it a little unique to put my maiden name in there.
Okay. Well, why don't you tell us what low-dose naltrexone is and how you happen to become one of the leaders? I know you were just lecturing in Australia at one of the very first international low-dose naltrexone conferences. So can you give us a background on LDN?
Absolutely. As you mentioned, it does come from a low dose of a drug that's been used for many years called naltrexone. And naltrexone itself is used for an opioid overdose. In baby doses or low dose or micro low dose naltrexone, it's a very strong anti inflammatory. And so we use it for any inflammatory condition, certainly any autoimmune disease. You mentioned some Hashimoto's, Graves' disease, ulcerative colitis, fibromyalgia, any of those. We always do three things for an autoimmune disease. And by the way, there's now 105 autoimmune diseases. And I'm sure you've covered this on your program as far as number one for an autoimmune disease, no gluten. Number two, what you're famous at, fix the gut. And then number three is to start low dose naltrexone. We use it for inflammation to prevent and treat memory loss. All forms of memory loss are inflammatory in nature, whether they're Alzheimer's or not. We use it for weight loss. Weight loss is an inflammatory condition. As you mentioned, cancer. For all kinds of cancer therapy, we're using low-dose naltrexone. So for almost anything you can imagine that is inflammatory, this is a drug that is absolutely fabulous to use.
Can you talk a little bit about the difference, how it got its name of low dose?
Yes, it is a baby dose. And so the most common protocol for this, it is compounded it to be a small dose, is to take 1.5 milligrams the first week, and then you ramp up the dose. The second week, you take 2 pills, which would be 3 milligrams. The third week, you take 3, so 4.5 milligrams. And then after that, people take 1 pill as 4.5 milligrams. There are other protocols. That's certainly the most common one used for an adult internationally, and it's usually taken an hour before bedtime. About 30% of people get insomnia the first night. It does tend to go away after that. If it doesn't, then we have people push it back and take it a little earlier in the day at 6 p.m. But it is used for many patients lifelong because we are getting great results. We stop it, the inflammation may come back. And so many people have been on it now for 5, 10 years for all these different kinds of therapies.
So, why is it that it causes insomnia, and why do we have to take it in the evening?
That's a really good question. It traditionally has been given at night. And I guess you would think maybe we should take it at noontime because insomnia is the most common side effect. But again, for most people, it only lasts usually for about one night. People can get nausea from it, although honestly, I've never seen that. In the hundreds of patients in my personal practice, I have not had any patients get nauseated.
So I was delving a little bit into how this all started, and there was this Harvard physician named Bernard Bahari. He died back in 2010, and he was very active in the AIDS and addiction community. And he started realizing that people are more prone to have worse progress with AIDS if their endorphins, these molecules that we think of as feel-good molecules, if they're low, they actually have a lot to do with running our immune system. And it turned out that if he was to recommend low-dose naltrexone between 2 and 4 in the evening, you increase your own natural production of endorphins by 300%. And those endorphins boost natural killer cells, T cells, all of your army to help keep you well. And in particular, to identify self molecules from something that's outside of the body. So I thought that was really interesting. And I'm one of those people, I have trouble with sleep if I take it later in the evening. And I started when I was getting ready for the show. He said, well, maybe you're taking a higher dose. He was saying that that might mean that person who has continued trouble with sleep maybe needs 1 or 2 milligrams. Have you ever
Exactly.
worked with that?
Absolutely. And really, what I do is a personalized medicine approach. And that's where medicine is today. Functional medicine is precision medicine or a personalized approach. And so every patient is treated differently. Do I have some patients on 1 milligram? Yes. Do I have some patients on 3 milligrams? Of course. The most common dose is 4.5. We do use it for weight loss because weight loss is an inflammatory condition. And so for some of my patients for weight loss, because they may weigh 300 pounds, then I might use 6 milligrams for those patients because they may need a higher dose. And then there's now micro doses where people use less than 1 milligram as well. So it is a customized approach.
So are you seeing in people who've battled the bulge all their life that if you add LDN to the mix of everything they're doing, they start shedding pounds more easily?
I do, because weight gain 100% of the time is inflammatory in nature. And so if we decrease that inflammatory response, and inflammation's very interesting. A little bit of inflammation heals. So if you fall down and you hurt yourself, an inflammatory response is set up. It's wonderful. It helps the body heal. What you don't want is long-term inflammation. When it becomes long-term, then it's counterproductive. And that's where LDN is wonderful, and weight gain is long-term inflammation.
Interesting. Now, when I started taking low-dose naltrexone, it was so much easier to do hachibu, which is remove yourself from the table before you overeat. I have noticed it's somewhat of an appetite normalizer. Have you experienced this?
I agree. I'm not sure it's an appetite suppressant. Some people think it is, but I think you phrased it very well, that it's truly it's an appetite normalizer. In fact, what I try and get my patients to do is to go to an antique store and buy a regular plate. If you look at plates from the 1960s, for example, the plates are smaller in size. And if you compare them to today's plates, they're larger. Just using a smaller plate, people use less food. But it is an appetite normalizer. So that's a great way to phrase it for low-dose naltrexone.
Cool. Now, one of the things I'm very interested in is its use in cancer. We know that there is a doctor in Las Cruces, New Mexico. His name is Bert Berkson. He has the same last name as myself. And when my book, Healthy Digestion the Natural Way, first came out, his book on alpha lipoic acid came out. We both were published by Wiley. We both were in New Mexico. So I got a box of his books and he got a box of my books. And that's how we met each other. And when I thought, oh my God, there's another Berkson in New Mexico doing functional medicine. And I realized that he was one of the few people on the planet helping people with pancreatic cancer live successfully, healthfully for a long time. One of his major tools was low-dose naltrexone.
Absolutely. It does, again, decrease inflammation. Almost every form of cancer is inflammatory, particularly breast cancer is extremely inflammatory in nature. And I love the other Dr. Berkson, Bert Berkson. In fact, that's how I started using alpha lipoic acid for memory, to lower blood sugar, to treat hepatitis C 30 years ago, was from his work.
Yeah, he's really incredible, and he is so generous and transparent. He has so much of his data up online, but still he has people successfully living 14 to 20 years out, having no more tumor burden, or they can cohabitate with the tumor burden, and he's giving IV alpha lipoic acid, low-dose naltrexone, and cleaning up their diet. And yet when people here in Austin, some of my close colleagues are diagnosed, not in functional medicine, in other fields, are diagnosed with pancreatic cancer, and they ask their doctor, well, what about Berkson? They tell them to avoid it because it's not accepted and it doesn't have a drug.
Well, it's unfortunate when we don't look at all modalities. When people say, do I do only functional medicine? No. I do believe in traditional medicine. I use traditional medications in my practice. But when I write a prescription for one, every single medication that a doctor writes a prescription for causes between 2 and 10 nutritional depletions. So when I write a traditional prescription, like for metformin to lower blood sugar, then where do I start? I start with exercise. I start with a healthy eating program. I give lipoic acid at 300 to 400 milligrams because it lowers blood sugar. If they need a medication, then I may give metformin, but metformin depletes the body of B vitamins and the very important coenzyme Q10. So I would do the whole breadth of this. May also give berberine and other nutritional therapies, because honestly, it's not about one or the other. It's about a personalized medicine approach. What will help that particular patient be better? Like Dr. Berkson, I have patients that for 20 years have been cancer stable, shall we say. They are living with their cancer in harmony. Everybody gets cancer. Most scientists believe 7 or 8 times in their lifetime. But there's 2 things that feed cancer: sugar and stress. So I do work with my patients like you do with stress reduction techniques and to help them have a better diet so they don't live on sugar.
So now we have another tool added to your incredibly common sense approach. That's what's always so frustrating to us in functional medicine, is we perceive our approach as extremely common sense. And what you just said to me makes absolute common sense. So now we're adding low-dose naltrexone as a potential tool. Would you say that it is applicable to all cancer patients?
I do. And it doesn't matter what kind of cancer the patient has when they come in to see me. I always start with try not to eat sugar. Let's do a saliva test and we'll work on your stress. And I do put them all on low-dose naltrexone. So in looking at my practice right now, breast cancer, pancreatic cancer, colon cancer, I have one patient that I'm treating now that had colon cancer. They did her colonoscopy. They didn't see the cancer. 3 years later, she ended up with abdominal pain, and it turned out that the cancer had spread to her appendix. She is doing very, very well now on just those same things. No sugar, work on stress, low dose naltrexone.
So one of the things and I'm going to ask you about your pancreatic cancer patients too in just a second. I want to write a note so I don't forget that. But one of the points that came up is that I get these emails here and there from people saying, well, if you use LDN for cancer, you're supposed to use it intermittently. And I can't see anything in the literature that supports that, but this is what's kind of rotating in some of the Facebook cancer groups. Can you comment on that, please?
I have not found anything in the medical literature to suggest in cancer patients we should stop low-dose naltrexone. So far I have continued it on forever, no matter how long I've been treating the patient. The longest I've had one patient on LDN for cancer is 8 years. And she's still on LDN and still doing very well because it is a wonderful anti-inflammatory agent.
So can you talk about your pancreatic cancer patient in particular? That really put my ears up when you mentioned that.
Pancreatic cancer is hard because for many patients, it's found when it's stage 4. So at the end of the disease process. But no matter what stage they're in, all of my pancreatic cancer patients do get alpha lipoic acid. They do the same sort of therapies. Please, no sugar. Let's work on stress, low-dose naltrexone. And a lot of their chemotherapy agents that they have used deplete the body in other nutrients. So this is where the oncologist and I usually have a discussion, because during their chemo, I would love to get those nutritional depletions. I'm not always successful in convincing the oncologist that it should occur during their chemotherapy, but certainly afterwards, I do go back and backfill those nutritional depletions. So let's say for breast cancer, we commonly use adriamycin. Adriamycin depletes the body of coenzyme Q10.
Right, that's part of the reason it causes heart damage.
It does. And so I've been successful, at least with Adria, in getting the oncologist to let me give it to the patient, the coenzyme Q10, during chemo. Because there's enough articles now to show that that is the main reason for the increase in heart damage that can occur with that chemotherapeutic agent.
I think there's even a study where they took about 12 women and gave half the group CoQ10 with the chemo and the other half without, and they tracked them. And the women on CoQ10 during the chemo didn't get the same heart damage. And it's so great that you have a relationship convincing your docs, because that's not always the case with a lot of functional docs. They're not always able to have a chat with the oncologist and benefit the patient in that way.
This is very true, but it is all about the science.
Right.
And the journal articles are there now. The clinical trials are there, whether it's CoQ10 or low-dose naltrexone, that these should be part of the standard of care for these type of patients.
So one of the comments that I was really diving into Berkson's articles on pancreatic cancer, because it's one of the worst, most difficult cancers. Chemo doesn't work on it. If a cell escapes, it's maddening because it's so overwhelming on the immune system. And I was able to find one article that I thought he was inferring that low-dose naltrexone helps fight metastasis, which is the cells leaving the primary tumor and traveling throughout the body, and that's really what kills you. Do you have that same feeling that if a cancer patient is on LDN, it protects them from metastasis?
I do. I'm not sure of the mechanism, and it may just be that this metastases in patients occurs because the inflammatory response continues. And that may be the actual mechanism. More research needs to be done, but we certainly see less metastases in people on LDN. They may still end up with stage 4 cancer, but the period of healthy time has definitely been increased in using low-dose naltrexone.
In your patients, like your pancreatic patients, do you give them the alpha lipoic acid orally or by intravenous method?
Either one. It depends on the patient's availability. It depends on cost. It depends on many things. I like to give it IV if possible, particularly for pancreatic. But if it's not, then we do give oral. One thing that our listeners today should be aware of is to work with your healthcare provider in this. When you give lipoic acid at 600 milligrams a day or above, it can negatively impact the conversion of T4 to T3, the thyroid hormones. So T3 being the more active. So you can give too much. And if you do need to give a larger dose of lipoic acid, and sometimes we do for hepatitis C, etc., then you do need to measure and monitor thyroid and make sure that conversion is occurring.
Are there any side effects of LDN on thyroid?
Not that we know of so far, and certainly would be helpful for people with Hashimoto's, which is an attack on the thyroid gland, because that's what an autoimmune disease is an attack on the body itself. And Hashimoto's comes in two forms. Form number one, people have just straight attack on the thyroid gland and it still functions fine. Or people can have hypothyroidism, low thyroid function with Hashimoto's, so it becomes an autoimmune process. And then people can have Graves' disease, where they are hyperthyroid. The body's producing too much thyroid hormone as an autoimmune response. LDN works great for any of these three situations.
Boy, that's really interesting. So let's summarize, because you're saying that LDN is a must for any patient with autoimmune disease. Now you're saying there's over 100 autoimmune diseases. Why don't you list the most common ones that you've used it for in your practice, so that people, when they hear this, or doctors that are listening, can think of this when they have patients walk in the door?
Well, certainly the most common autoimmune diseases everyone thinks of are things like Hashimoto's thyroiditis, because 70% of people with low thyroid function do have the autoimmune process. They do have Hashimoto's. So with low thyroid function, it's common for it to be an autoimmune process. But ulcerative colitis and Crohn's, Graves' disease, fibromyalgia, chronic fatigue, are autoimmune diseases. People don't always think about them that way, but they are. And the 105th autoimmune disease is now listed as chronic Lyme disease. So when people have Lyme disease chronically, because it's not treated initially, Lyme disease is a very interesting process. It is a spirochete, and the only other spirochete that we know of is syphilis. And I've been practicing long enough that when I was a young doctor, I did see syphilis. And again, if you don't treat it initially, that's the best anti-aging. Thank you. You do not either, so it's beautiful. It's the anti-aging use of both of us. But in all seriousness, when you look at spirochetes, if you treat syphilis or Lyme disease initially, then it doesn't get stored in the body. But I like to think of Lyme disease, if you don't treat it in the first 6 weeks, and you get secondary or tertiary Lyme, meaning chronic Lyme, then it behaves like a Klingon. The spirochete hides. And so if you're a Star Trek fan, you know exactly what I mean. It's hard to find. And one of my mainstay treatments for Lyme disease, amongst many other things that you've discussed on your show, okay, but for a lot of them, one key thing is all my patients with Lyme are on low-dose naltrexone.
You know, that was interesting. I brought up an interview that when he died, his widow made available to have transcribed. And in this interview with Dr. Bahari, and he's really the guy that put this on the map. In fact, he's even come up with certifications for pharmacies to jump through all these hoops and become what is called Bahari certified. And so there's about, to my knowledge, about 9 compounding pharmacies. Doesn't mean that pharmacies that aren't Bahari certified can't make low-dose naltrexone, but they've really got themselves very intimately involved with Bahari's protocol, and he's the physician that first came up with all of this. In that interview, he said that it was a very important component for treating Lyme disease.
That's very fascinating. So early on, he recognized this because Lyme disease is extremely inflammatory, and it does settle down that component of inflammation.
Very interesting. He also said that one of the things that low-dose naltrexone does is it boosts inside your body endorphins. And he said that we're now even maybe thinking that a deficiency of endorphins is what makes us prone to get cancer or various other illnesses in the first place, because endorphins, or these feel-good molecules, are a big part of keeping us well. And that's why attitude and meditation and exercise and things all add up, because they help shore up our endorphins. And I thought it was so interesting that he said why this is so good for autoimmune disease is that when you take low-dose naltrexone and you boost hundreds of % your own production of these feel-good molecules, endorphins, it trains your immune system not to attack your own tissues, which is what autoimmune disease does. So it's a retraining. It's not only a super immune booster, it actually takes your immune system back to school.
Well, it does. And you can teach your body different things because it does affect the cytokine system and how the immune system works. And very importantly, low-dose naltrexone, because when the endorphins go down, pain goes up. And so LDN works in this mechanism as well. It's part of the reason we use it for pain control.
Can you talk about how you do that? Do you put it in a cream? Do you still do it orally? Tell me about that.
You can do it either way. One of my favorite ways is to put it in a cream. So you can use low-dose naltrexone, again, compounded, and apply it right to the area where there's pain. In fact, I wrote a prescription for it this morning. I wrote 2 pain control gels that were compounded for my patient. One for low-dose naltrexone to be applied by itself, and then the patient had a second pain control gel with lidocaine, ketoprofen, DMSA, other medications that help in other facets of pain control. So she's going to be using the second one twice a day and the LDN twice a day at opposite every 4 hours.
What kind of pain does she have?
She has sciatica, and it's radiating into her right hip. And she's so cute. She's just the cutest patient in the world. She'll be 88 in December. And when we write prescriptions for things of this nature and that age group, we have to be careful because of kidney function and liver function. But she has perfect kidney and liver function, just like she was 25.
If
And so
somebody had compromised renal function, would they be less a candidate for low-dose naltrexone?
great question. They could use LDN, it's more cleared through the liver. If they had compromised liver function, then we started a lower dose. The interesting phenomenon, not yet published, but very interesting, we're seeing what we call anecdotally in medicine, meaning we see it in practice, but it hasn't been a clinical trial yet. What we're seeing is that sometimes people that have elevated liver enzymes, it's an inflammatory process. When we give the very low dose naltrexone, the liver enzymes, particularly for fatty liver, start improving.
So, like at 1 or 2 milligrams, or
Or
do you
even
mean
half
a
of a milligram.
microdose, which is underneath 1 milligram?
Exactly. So I
Okay.
had one patient on 0.25, which is a fourth of a milligram. I
Uh-huh.
have two other patients on 0.5. They're doing very well for fatty liver because it's
Oh,
decreasing that
interesting.
inflammatory component.
Very interesting. Well, I've been here at home in the quarantine, and I can handle that, but I'm such a cardio active person, and I have plantar fasciitis that happened after I broke a toe, and then it just created problems with the fascia on my foot. So you probably know Jim Hinseer that owns Las Colinas. I was bemoaning to Jim because he and I text and write each other quite a bit. We're big fans of each other. And I told him about this, and he's been recommending for my foot. I haven't gotten the prescription yet, a prescription of low-dose naltrexone mixed with something else. And I've tried everything else, and I've done the boot, and I've done the exercises, and nothing is working. Even resting off of it isn't working. And so I was going to try that next, and I'll have to let you know how it works.
Oh, absolutely. Let me know because it is phenomenal. Because again, a lot of pain, it's an inflammatory response. And when it helps with endorphins and inflammation, it's perfect.
Wow, it's a real big winner. And of course, we hadn't mentioned yet, but a very common autoimmune disease is multiple sclerosis.
It is. And I see a lot of that in Michigan. MS pretty much occurs north of the Mason-Dixon line, we used to call it. So the idea is if you live in the northern states or northern part of the world for that matter, okay, where it's cold all the time, and you live in the north, then you tend to have a higher rate of MS. If you live in the southern tier states or other parts of the world where it's warm all the time, and you live there until you're age 12, the incidence of MS is almost zero. So I do see a lot of MS in my practice. We use a lot of things like phosphatidylserine. In my book, What You Must Know About Vitamins, Minerals, Herbs, and so much more, which just came out a few weeks ago.
We're going to hear a lot more about this because this is a book you've got to get. It was another reason I was excited to have Dr. Smith on the show.
In my book, we describe different nutrients. And then in part 2 of the book, we actually go through different disease processes. So if you look in the book under MS, it will list low-dose naltrexone. It will list do not have dairy, do not have gluten, because both of those things tend to be a problem for people with MS. And then there are different nutrients like phosphatidylserine, which is very well known to help with memory, but it's also very effective in people who have MS.
Interesting. Now, how come when people have a flare of MS, usually they could be pretty long, if they get IVs of glutathione right when they're initiating the flare, I've noticed that this really shortens the duration of the flare. Have you seen this?
Absolutely. And that has to do with the free radical production that occurs. As everybody I think out there knows, but just to make sure, when you have free radical production, really there's a lack of an electron. The body goes searching for an electron, and the body finds an electron, it steals it, and it sets up this response that occurs in the body with free radical production. And then you end up with inflammation, and you can go on and on with oxidative stress and these big medical words. Well, what it really means is the body, again, is trying to really set up a response that is not healthy. So we can help in many ways. Coenzyme Q10, for example, is very, very good for free radical production, as is what you just mentioned, glutathione. And so glutathione we do use for Lyme disease and almost every other disease process we can think of that really has free radical production in it. So I love IV glutathione. It also comes as a liposomal form now, so that we don't have to give it IV. We can give it as a liquid. We can have it compounded as a pill, but it is a mainstay for many of these different diseases.
Now, at some of the A4M modules, which are absolutely amazing, and if there's any people that really want to get certified in functional medicine, A4M is a group that puts on these incredibly in-depth and helpful modules, and at the end you take an exam and can become board certified. And we had this quite extraordinary lecturer, and she was talking about how asparagus is the highest food source of glutathione. And she had one patient that wasn't able to come in and get an IV or liposomal, and was really battling stage 4 and had failed regular chemotherapeutic interventions. So she recommended that she have 2 cups of asparagus a day on an ongoing basis, and that patient long-term is still alive and faring well, supposedly from the high glutathione content of the asparagus.
It's always best to eat your way into everything you can. We tell people that all the time. Please start with the food. Start with a great diet. There's, in my book, What You Must Know About Vitamins, Minerals, Herbs, and so much more, we list the foods of all the nutrients too. So if you want to know what foods are high in calcium, etc., the whole food list is there as well. It's always great to eat your way into it first.
I love that. By the way, you're gesturing a little, and I've never seen you in blue nail polish before. For those of you that are just listening to the show, I just have to comment because I've been lecturing with Dr. Pam for a really long time, and I've never seen you wear blue nail polish before. And it's really super, especially for gesticulating and getting a point across.
It's actually purple with a little bit of blue specks, but it's really kind of fun. As you mentioned, when you are stuck home here, what do you do? And so my nail stylist happens to be my nail stylist for over 20 years. And of course, the nail salons are closed. And, you can have, 1 or 2 people over. You can't have more than 10. And so she's been coming to my house and doing my nails and doing my pedicure instead while everybody's quarantined. And so we just decided to do a really fun color. So thanks for noticing.
I really love it. So if someone is just hearing about you for the first time, or even if people have been to some of your lectures, what do you think are the top few books that people would benefit the most from purchasing that were written by you?
Oh, thank you for asking. Obviously, What You Must Know About Vitamins, Minerals, Herbs, and so much more. My book on thyroid, Much You Must Know About Thyroid Disease, really looks at regular thyroid function. It looks at low thyroid function, high thyroid function, and the autoimmune process. So it is really all-inclusive when it comes to thyroid. What you must know about memory loss and how you can stop it. So it's for people who don't want to have memory loss. It's also for people who have cognitive decline, to see what else they can do. I co-authored one book, the rest I've written by myself, and it was fun to co-author a book, What You Must Know About Allergy Relief. And I wrote it with a compounding pharmacist, and it's a great book because it becomes really from a physician's viewpoint and from the viewpoint of a pharmacist. So you get the benefit of both when you look at the allergy book. And then, of course, I've written a book on weight loss, what you must know about weight loss. And so it's important to look at all these different areas. It depends on your interest, but my favorite book that I've ever written, What You Must Know About Women's Hormones, is still my favorite book that I've ever written.
Now, we're going to have the links. We're going to have in the show notes, which will be up on iTunes and is also up at drlindsayberkson.com. If you click on the podcast, there is a picture for each show, and underneath it, there's show notes. And we'll have Dr. Smith's show notes. And at the end, we will give a list of her books and a link where you can just click on the link and go to that book and purchase it. We'll also have her website because she's still actively in practice. In fact, we recorded the show on Wednesday this week because she was doing telemedicine with her own patients on Monday and Tuesday. Interesting fact, Pam. I worked for almost 10 years in a dialysis center with Dr. Jack Moncrief, who co-invented the home unit. of dialysis. And he's a visionary dude. I mean, a visionary dude, a small little guy in the presence of a huge giant. And we've stayed really close friends. He came up with the idea of telemedicine, and he went to Bush and he signed the bill in with Bush. So when you walk into his office, he's got pictures of him signing the bill in with Bush, besides his own catheter that he has and continuous ambulatory peritoneal dialysis. That's the home unit, because the very first baby born without kidney function, he designed the unit for this baby. The baby survived, and now the baby went to med school and is now a kidney doctor.
Oh, that's awesome. What a great story.
Yeah, he's totally cool. He plays the trumpet. He's got a wedding pavilion. He's got his fingers into everything. And, it's my dream to do a functional medicine renal module, hopefully. And I want to bring him in on it a bit. If we can, we're trying to develop enough patients that we take from kidney disease to normal, so that we have enough data to do that on. So let's just go back to the show if we can. We're starting to be toward the end of the show. So we're thinking of comments that we want to make sure that we get out there besides your books, which are really, it's a lot of energy to write a book. And when someone teaches, like Dr. Smith does, nothing gets you to know a topic like teaching it and then being able to clinically use it on your own patients. So you bring that to your books. And then, of course, writing a book makes you hone yourself on the topic. And I myself do all of that. And people don't realize how much that gets you as an expert into the nooks and crannies of the topic. So is there anything else that you want to say on low-dose naltrexone? I did have one patient that was a gentleman that's had serious chronic fatigue. He has seen so many top functional medicine specialists. And when he tried LDN, he's the only patient, because I too have worked with about several hundred patients with it. He would tank from it. He would get worse. And we couldn't ever get him, no matter how micro dose we would give him, even 1/4 of a milligram, he had an adverse effect. So it's rare. And it's usually just sleep issues, but on him it was different than that. And there was also another doctor that had gone to one of my courses, said every time she took LDN, she had some tremors. And she'd go off of it, the tremors would go away, she'd go back on it, they would reoccur. So she could do it on demand, so to speak. So if you are the rare person that is having some very rare atypical issues, what might you think and what might you do with those patients?
Well, before we really give anybody anything, whether it's LDN or not, if you're going to give something orally, it's your topic, Dr. Berkson, fix the gut. I have found that more and more of my patients can take on LDN or any other nutrient for that matter to make sure the gut is healthy. As much as I love to talk about hormones, if you ask me, is the gut more important to be healthy than hormones, or hormones more important than the gut? I think you and I agree. The patient's not healthy until both are taken care of. I've also found that a few people that haven't been able to take LDN well, if I put it on the skin, it was helpful. But I've also found a couple of my patients that couldn't take it, I was missing other disease processes. So I'm thinking of one of my patients in particular that had to stop it even at 0.5 milligrams. And to make a long story short, the person had toxic mold syndrome. Oh. When we treated the mold, then we went back and started the low-dose naltrexone at 0.5 milligram, no problems. But we had not treated the mold first. So again, it is a personalized medicine approach.
Right. That's a really good point. So I had a very powerful experience with LDN personally, in that I've always had a lot of problems with upper respiratory diseases, which of course now we have an upper respiratory virus going around. And I guess there's a genetic pattern that puts people more at risk for ARDS, acute respiratory disease. But so all my life I would go toward chronic bronchitis or pneumonia. And when I started LDN, it stopped it for the first time in my life, just completely eliminated it. And you and I both know a colleague who has a very serious inflammatory bowel disease issue and isn't quite ready to make the go off gluten, the dietary changes. And many people in the family also had the same disease. And when that person went on low-dose naltrexone, just that one addition, they put their out loud inflammatory bowel disease silent and down and healed. So you have to think outside the box that LDN might be a potential tool for a wide variety of issues.
Absolutely. When I actually do a gut health test on a patient, and most of my patients eventually end up with a gut health test, at least 70 to 80% of them have positive inflammatory markers. So when they end up with diarrhea, constipation, reflux, whatever the situation may be that we want to do a gut health test, remember 70% of the immune system's in the gut. Serotonin, the happy neurotransmitter, is made in the gut. There's so many things. Biotin for hair and nails is made in the gut. A healthy gut equals a healthy person. If the gut is inflamed, the patient is not healthy. And LDN, I think, is going to emerge as really something that helps the inflammatory component in the gut that really hasn't been discussed enough yet in the medical literature.
So you talk a lot about its role for the brain. And I know in that interview with Bahari, the founder, so to speak, of the use of low dose, because remember in the ER, if someone overdoses, you're giving about 50 milligrams. And we're talking at doses under 6, anywhere from micro milligrams to about 6 milligrams. Bahari said that the microglia caretake the brain cells and that low-dose naltrexone caretakes the microglia. So if someone came into you, Dr. Smith, with cognitive decline or Alzheimer's disease, would you consider LDN therapy?
All my patients with memory loss are on LDN. And as you know, Dr. Berkson, there is a gut-brain connection. And so if there's inflammation in the gut, there's going to be inflammation in the brain. So we do have to go back and fix that and make sure the gut is healthy. But all forms of memory loss, Alzheimer's or not, are inflammatory in nature. So in my personal practice, along with my partners, and I'm blessed to have 4 of them, all my partners, we do use LDN to prevent memory loss and treat memory loss.
What about psychiatric issues? Is there any link with that?
That's a great question. I'm just starting to explore that now. I'm actually writing a talk at a conference you and I are going to be speaking at together. And one of the things I'm going to be writing on is hormones and psychiatry. But as I started looking up hormones and psychiatry and depression, anxiety, et cetera, and the hormonal connection, I started pulling up these articles where LDN was being used for anxiety, et cetera. So much more to come on that subject.
So we're getting close to the final part of the show. Is there any condition that we haven't mentioned that LDN might be considered for? And what's really exasperating is that still a lot of doctors don't know about it, and what you're not up on, you're often down on. And so when people hear this show, if they're not a doc or a practitioner and they want to go get this, they might have problems. Just to let you know, Belmar Pharmacy in Golden, Colorado, which is Bahari certified, it jumped through all of Bernard Bahari's hoops to get this certification. They have a practitioner online that you can work with, although it's a little bit of money, $150 twice a year, just so you know that there are some ways, especially when we're moving online right now during the quarantine. So if you hear this show and you want to get it, but it's better to work with a doctor that knows your own personal medical history and the whole having done a physical on you and so forth. But that's pretty interesting. Is there any disease process that you've seen success with this, but we didn't mention?
We should mention the fact that there is a counterindication to low-dose naltrexone. Beside pregnancy, that's a different story. But if someone is on a controlled substance for pain, they're on morphine, heroin, etc., they cannot use low-dose naltrexone.
Even if it's in the microdose?
In the microdose, it's still up for discussion. Certainly starting at 1 milligram, it would be a counterindication for the use of the drug.
So again, if you're pregnant or if you're on drug meds?
If you're on some heavy-duty drugs, pain meds, even Tylenol with codeine, probably not a good use is LDN.
But not Tylenol by itself, right?
Not Tylenol by itself, not Advil or any of those kind. That is fine. It would just be an actual narcotic that would be an issue that's used for pain control.
Okay, interesting. So Dr. Smith is really somebody who has her finger on the pulse of what's going on in functional medicine. She trains practitioners, from medical doctors to chiropractors to naturopaths, and she herself has been an ER smart doc and then taken all that history and mixed it in an integrative manner. So really, her books should be on your must-read list. We mentioned them quickly. You can go to the show notes. You can look at each book. You can decide which top 3 you're going to want to get or give away as gifts to somebody else that you know has a problem. There's also a great book that one patient whose life was turned around by LDN was so grateful for it being available that she went and interviewed 12 physicians and their stories using LDN, some of the best and the worst stories. So that's a great book as an introduction. It's called The LDN Story, and I'll put that also in the show notes. Do you have for us, as a final few minutes, a very fascinating little, I didn't prepare you for this, so I'm not sure what your response is going to be, a patient's story that was quite mind-boggling using LDN?
Absolutely. I have a patient that at 25 years of age, she infarcted off 6 feet of her ileum. That means that she lost part of her bowel. And what happened is she had had her surgery on her ovary. She had developed adhesions and things that should not really have occurred with scar tissue. When she went to deliver a baby at the age of 25, which was her first child, the bowel wrapped around the ovary, and she ended up infarcting off or losing all of her ileum to the ileocecal valve. You need your ileum because that's B12, etc. That part of your bowel is a very, very important part. In fact, she was so sick. She had a 10-day-old baby. She was in the ICU for 30 days. She was in the hospital for 2 more weeks. And having lost her bowel, she thought she would be on B12 shots forever. As it turned out, the jejunum, the other part of the bowel, takes over for the ileum if you're really young. And that jejunum took over. She didn't need B12 anymore. In fact, she's in the annals of surgery, the youngest patient to ever have a volvulus, age 25. And that was in 1978. But when you don't have a bowel that works, it becomes inflamed. If you don't eat right, because when you put sugar in, it's inflammatory. It becomes dysfunctional with age because it's harder to control electrolytes and things of that nature. So potassium and all of those that regulate the heart rhythm become dysfunctional if the bowel doesn't work properly. So she ended up having to have atrial fibrillation and a cardiac cath and a cardiac conversion twice to fix the problem with her low magnesium and low potassium that occurred because her bowel didn't work. When she started LDN at a baby dose, 1 milligram, that inflammation settled down. That patient is me. So I have a very personal story that I love sharing with people about the bowel and how important it is for health. When it becomes inflamed, the patient's not healthy. And one of the best ways in the world to help that is low-dose naltrexone.
That's so great. Thank you so much for sharing that. And we now think that so many diseases are inflammation out of control in that local area of the tissue that's creating them, presenting as a disease. So it's something for us to consider in so many conditions: autoimmune, pain. Oh, right before we leave, I'm glad I mentioned that, and inflammatory conditions and memory and cognitive conditions. If you're using it for pain, do you get as much benefit taking it orally, or do you lean much more on compounded lotions? And what are the different pain syndromes you have successfully used LDN in this manner that you're going to share with us what that manner was?
Well, a lot of it has to depend on whether the pain is all over the body or it's localized. If the pain is localized, then certainly LDN compounded as a transdermal cream on the skin works great.
And it's still low dose?
It's still low dose. Absolutely.
Okay.
If someone has fibromyalgia, for example, chronic fatigue syndrome, where they may have pain all over their whole body, they may have Lyme disease where they have pain everywhere, or other conditions, then it's best given orally for that and not really for on the skin. So on the skin is best for a localized pain control.
Excellent. Well, I hope that we get to lecture with each other throughout the rest of our careers, because it seems like we are born to do this, and there's so much mutual respect. And I'm sure that this one show is going to help and ripple out so many people throughout the world. I'm sure of it. And thank you for all your books. Being an author myself, I know how hard they are. And we're even whispering some possibilities of some collaborative things in the future. Thank you for giving us this time, Dr. Smith. Is there any final thing you might want to say?
Thank you so much, Dr. Berkson. It's really been a pleasure to be on your show today. And to finally conclude, medicine now in 2020 is at the forefront. It's not just COVID-19. Medicine now has changed. We are able to provide a personalized, functional, precision, anti-aging approach to healthcare. So please seek out a healthcare provider who is trained in this area so that you can receive a personalized approach. Everyone deserves that kind of healthcare.
Thank you so much. And if you love shows like this, this is an amazing show. And you were able to hear so many nuances, and it's all about nuances because someone who uses this information on herself and on her patients and teaches it and writes it. If you love shows like this, please go to iTunes and leave us a review. The 3 steps for which to do that are at the bottom of each show note. If you want to tell us more topics you would like, if you have questions, you could reach me at info@drlindsayberkson.com, and please go to drlindsayberkson.com. I have a brand new updated article. It's the second version of my updated integrative approach to understanding COVID basics and therapeutic approaches, and it's also going to be published in the Townsend Letters COVID issue. So staying in touch with our clan helps you keep in touch with how to best serve your patients and to stay well yourself with experts that we've been so blessed. That's a whole career of a lot of elbow grease to be able to sit and share the information that she just has. So thank you, Dr. Smith, and everybody be well.
Thank you so much. Goodbye, everybody.
Bye.